move on to our next session, which is on RCC. It gives me great pleasure to introduce our session director, Dr. Vineet Talwar, medical oncologist from New Delhi. We have our chairpersons who have joined virtually, Dr. Ganesh Bakshi, senior urologist from Mumbai, and Dr. Hemant Tongaonkar, senior surgical oncologist from Mumbai. I would now invite our moderator, Dr. Amit Joshi, medical oncologist from Mumbai. He'll be talking on the panel discussion will be on real world cases encompassing SX, radiotherapy and medical issues. Our panelists are Dr. Vinayak Maka, medical oncologist, Bangalore, Dr. K. Govind Babu, medical oncologist, Bangalore, Dr. Deepak Dapkara, medical oncologist, Indore, Dr. Sayan Kundu, radiation oncologist, Kolkata, Dr. Chirag Desai, medical oncologist, Ahmedabad, and Dr. Anupam Datta, radiation oncologist, Kolkata. I also request our chairpersons and session director to please join the panel. Thank you so much.
Thank you, Kashish. And with this, we move on to the RCC discussion. We'll do a threadbare discussion about the nuances of treatment, whether it is in the adjuvant setting or sometimes in the neoadjuvant setting, and broadly it is in the metastatic setting. So for that, I request my dear friend, Dr. Amit Joshi, to come and take over, please.
Thank you, Dr. Vineet. So I think we'll start this session. Is Dr. Ganesh or anyone from online is there? Is online? Yeah. So I think we'll just start with the, so I think the panelist for this is Dr. Amit Bhatt cannot join because, and Dr. Govind Babu. So we have today a full-fledged, very solid, strong medical oncologist panel, and with Dr. Sayan from radiation oncology. So, and Dr. Vineet, Dr. Vinayak and Dr. Chirag, they are all, Deepak, you can also come and join. So it's a full-packed medical oncology session with some discussion for the surgical oncology. So we'll start with the first case, and I think Dr. Hemant Tongaonkar sir or Dr. Ganesh is on line. So that is the first case for discussion for them. So this is the usual case which we see in our OPD, that a 58-year-old presented with painless hematuria. So on further subsequent workup, he was found to have a renal mass. And this was his blood parameters, which is more or less equal, normal. So this is the CT scan imaging finding of this patient. So if Dr. Ganesh or Dr. is online, can I request them to can I request them to comment on this lesion that what are the differential diagnoses in this case, and how to go ahead in this case. If they are not on the line, then I can request Dr. Vineet to have some throw some light on the how they follow these patients in the OPD.
Hello. Hello.
Yes, sir. Yes, sir. Dr. Hemant Tongaonkar is online. So, sir, this is a case of a 57-year-old male presented with painless hematuria for last 10 days. On routine workup, all investigations were normal, and a CT scan we find this mass. So, what are the differential diagnoses we should consider, and how to go ahead? And the rest, CCT thorax is normal, and there are no other. So, this lesion is confined to the kidney only.
See, basically, this is you can see there is no plain film, but this looks to be a enhancing mass in the kidney, and with necrotic areas there. So this is likely to be a renal cell carcinoma. And I don't think there is any differential. This is a typical RCC. Of course, I don't know the other local extent. I can't see the CT scans too well. But otherwise, if there are no lymph nodes, has any metastatic workup been done?
Yeah, so CT thorax is normal, and
Okay.
and alkaline phosphatase is also normal.
All right. So it's basically a localized renal cell carcinoma.
So
So
in
it
this case, you
requires
like to go
surgery.
ahead with the upfront surgery. Do you need to do a biopsy of this lesion before going in, or
No,
FNAC?
not at all. I think any mass that enhances on contrast and with enhancement which is less than the normal renal parenchyma is malignant unless proven otherwise. So I think you need to go ahead and do the surgery. I don't think there is any role of biopsy here. Biopsy is indicated only if you are suspecting something like a lymphoma. There are large nodes there and a renal mass, or something like an abscess. But otherwise, for a mass like this,
Is
there's
not
no
like it.
need of a biopsy.
So the next question I can ask Dr. Ganesh, he is online. So what are the conditions where you need a prior biopsy for a renal mass before going for a surgery? Is there any specific subset of the patient where you want to need to know the type of histopathology lesion before going for surgery?
As sir was saying, we need renal biopsy in indeterminate masses, which may be slightly contrasting and CT-wise indeterminate. We are not getting lymphoma with multiple other lymph node sites, or in some cases where I would like to do an active surveillance, I would do a biopsy, and in some cases where I know it is metastatic and need a biopsy to go ahead.
So I think if the radiologically the lesion is typically has an enhancing feature, so the first thing is to go ahead with surgery if there is a non. So there are rare situations like a very young patient sometime, but we encountered that a very young patient with renal mass, the differential diagnosis can include a PNET of a kidney or a sarcoma, or radiologically the differential diagnosis will other than the RCC, and rarely some patients which have a origin near the pelvic system where the possibility of a pelvic TCC or pelvic. So generally, if radiologically it fits into the criteria, we should go ahead with the surgery if it is non-metastatic. So the final histopathology for this after the operating is a clear cell RCC, IUSCP grade 3 with T3 and N0, it was M0 and no sarcomatoid component. So now the question comes the adjuvant therapy in RCC. So I think I will start with Dr. Deepak. So what's your take call on this? What are your thoughts, and what you practice in your day-to-day setting, where you place the adjuvant in our RCC?
No adjuvant treatment for this patient.
At all?
No.
Dr. Vineet, what's your take on call? So regarding the TKI and regarding the IO, so do you consider in some cases, any case where you want to consider TKI, sunitinib, or that is practically out, the sunitinib is practically out despite a positive abstract data with the FDA approval and with this the DFS benefits showing. So where you place the TKI in adjuvant?
So there were 4 trials in adjuvant TKI setting. Out of that, 3 were negative, and only 1 was positive, as you shown the abstract trial, and that too it was the DFS benefit. There was no OS benefit.
So the question is, right, so it is the only DFS. Why you don't want to consider? If you extrapolate the pembrolizumab, is still the DFS benefit. So do you want to go the same philosophy of no DFS benefit in TKI versus the same in pembrolizumab?
So fortunately, there was a meta-analysis after this study, and it was found that the use of TKIs had practically no benefit. In fact, they were adding to the morbidity profile of the patient, despite the fact that the patient might be in a good PFS condition. Your argument is fair enough that DFS can be taken, but then, this is an adjuvant setting. This is not a metastatic setting. So here, you have to really weigh the morbidities which are, assumed by the drugs vis-a-vis the actual benefit which is there. So this was regarding the TKIs. Now coming to so TKIs is no.
I think, Chirag, what's your take on called adjuvant TKI? Then we'll discuss the immunotherapy. So in your practice, adjuvant TKI is out?
Practically, yeah. I mean, when abstract data came in, I tried in a few patients, but then I had to stop adjuvant TKI in a few patients. And then meta-analysis came, the subsequent data came, then last couple of years I have not been treating with adjuvant TKI.
Vinayak, what's your take on call? And then I think Dr. Govind Babu sir is also online, so we can take his opinion.
So I have not used TKI in any other patients with adjuvant, but I would prefer to use TKI in patients who are non-clear histology because data is there for that, one. And second, in liver limited disease, when they can't afford a complete resection is done, the 1 or 2 lesions where they're limited disease, there I may offer TKI.
So M1 NED situation
M1,
like
M1
you
who's
want
resected,
to
yeah.
If Dr. Govind Babu sir is there, he can also comment on the use of the adjuvant TKI in day-to-day setting. Still that is in the radar or not? Is sir is on the line, Dr. Govind Babu sir? Sir, you are muted. So
Amit, if I may add, in the TKI trials, there was no M1 NED.
Yes, so that you are right that in those criteria, this is the new terminology which has come up with the pembrolizumab. So I think what the all consensus of all panelists that although there is some DFS benefit data is there, but still because of the toxicity and the profile and the mature data is still not showing OS advantage. So practically the chapter of adjuvant TKI is practically out. So I think I will start discussing the adjuvant pembrolizumab. Deepak, what's your take on call with adjuvant pembrolizumab after in this?
I am not sure.
So if any patients come with this indication for this which has approval also, do you still not want to discuss with that or any subgroup of, or you do not just want to give and keep the immunotherapy reserve for unfortunate progression at some point of time?
See, again, with this keynote 564, there were 3 typical situations, those who benefited, and that was T3, T4, and N1 and M1 NED. So it was seen that the maximum benefit was seen in M1 NED patients, although there was a benefit in node positive patients also. The least was with T3, T4 patients. But like the TKIs, here again you have only the DFS benefit. You don't have the OS benefit because the number of events have not reached. Probably it will require another couple of years for the events to reach, and they would come to a conclusion about the overall survival. It may be there, it may not be there, but then having said that, you have a patient who's a very fit patient who doesn't have any autoimmune problems and not many comorbidities, because this has to be given over a period of 1 year. And along with that, you have to make sure that the financial morbidity is not there, and have to explain threadbare. It has to be counseled that it won't be 100%. It is going to be a fixed percentage of patients that will be benefiting, and there might be failures.
Chirag, how you counsel? So the most common problem which we face in OPD that the family will ask, say, is there any drug available to prevent the recurrence? If we take the drug, how much will get benefit and what are? So any subset of the patient which you want, or you don't want to consider pembrolizumab in all patient adjuvant?
So I will want to look at the updated data, but as he already said, maybe M1 NED patient will be the best suitable patient for this type of therapy. But having said that, I will say that there is a desperate need of some adjuvant therapy which comes as effective. So the need is there. Unfortunately, whatever we have done so far has not met with that need.
Vinayak, what's your take on call?
It's a difficult choice, sir. I mean, like the cost, there's no
The
support.
cost we removed for the discussion sake of discussion, we removed the cost. So even if the cost is not a constraint, do you want to consider in some subset of the patient, or we want to keep it reserved for progression since there is no OS data matured yet now?
Some are not able to understand that IP and U failed, and this is going to work. There are immunotherapy is not for every patient. We know it from experience.
So for sake of discussion, when we sit in OPD, when any affording patient, the real problem starts when affording patient comes, when you have to take a choice.
So if it is doing it, it will be done in the same in the M1 NED, and node positive, if it has to be there.
So I think what you, yes, Chirag.
If I can have a comment, many of my uro-oncology colleagues are also reluctant to go for the nodal dissection in RCC patient. And if one of the surgeon can enlighten us on the reason for
So
not
I think
doing the node dissection.
Dr. Hemant and Dr. Ngaonkar sir can comment on this, because in this trial the node positive patient were qualified for a adjuvant therapy. So doing a nodal dissection in a normal day-to-day surgery, generally what we have learned that it has not a survival benefit, it's a prognostic. But with this data, do you still want to go ahead with the nodal dissection in all patients or not?
I think Chirag is absolutely right that till date, no trial had shown survival benefit with routine lymphadenectomy at that time of renal cell carcinoma. But with this new data of adjuvant therapy coming in, I mean, if you don't do node dissections, you will not identify patients who are node positive, obviously. So I think at least in patients who have a T3, T4 disease, those who have, a grade 3, a kind of a high grade disease, and the size which is more than about say 10 centimeters or so, I would certainly go ahead and do the lymphadenectomy. I mean, that's my routine practice. At the same time, at least the higher lymphadenectomy should be done in every case because it is right in front of you. And if there is that tissue can certainly be removed at the time of radical separation.
So I think
I think one should be doing a kind of formal lymphadenectomy, at least in larger tumors, high-grade tumors, T3, T4 tumors, certainly, no question.
So I think I will just take the, if Dr. Govind Babu sir is online, so we'll take the final call from sir and then we'll just wrap up with few slides for adjuvant.
Yeah, Dr. Joshi.
Okay, so I think recently concluded ESMO, I think there are at least 3 trials which have looked towards the role of a perioperative immunotherapy. So this was a PROSPER trial which looks towards the nivolumab perioperative and adjuvant. So this trial, it's a little bit complicated design. So they have given the nivolumab pre and post surgery also for at least 10 weeks. And this was also a negative trial. There was no benefit in terms of that. The other was the Emotion 10 trial where they used adjuvant atezolizumab. That was also a negative study. There was no benefit in terms of the PFS. And the third, which was, we thought that this may be a positive study, the combination of nivolumab plus ipilimumab versus placebo in a localized checkmate 914 trial where the patient of a high risk, like the previous keynote trial, they randomized onto the placebo versus nivo plus EP as adjuvant. And unfortunately, this trial was also negative. So there are 3 back-to-back trials which is negative. So I think with due course of time, the adjuvant, the initial hype up was which so slightly the benefit seems to be not of that magnitude which is seen. So I think Govind Babu sir is there. So sir, what's your take on call regarding adjuvant immunotherapy with 1 positive and 3 back-to-back negative data?
Yeah, Ashish, I totally agree with you that these 3 studies which have shown no advantage at all. In fact, it's surprising that all 3 were negative. So people thought the IO plus IO should definitely benefit, especially in the high risk, and that also has turned out to be negative. I think it's good for the patients that we don't have to resort to
So I think
expensive drugs for the adjuvant.
I think this what we are discussing, sir.
So
so even in patients who are what the Dr. Vinit was regarding the M1 NED and the sarcomatoid. So I think these are the in current era, these are the 2 soft indications which can be discussed with the family regarding the benefit of the adjuvant immunotherapy rather than all patients. So I think we can conclude that these are the subgroup of the patient which can benefit with the adjuvant immunotherapy.
Yeah, see, once you are a M1 NED, then it is a systemic disease. These patients are bound to relapse after some time or the other. Probably this would be the best bet as far as the adjuvant is concerned.
So I think the next the discussion regarding the cytoreductive nephrectomy. So I will ask first with Dr. Chandrakanth, sir. So where you place in current era for both TKI era, and still we used to give TKI in more than 90% patient, at least in our patient population. So where you place the cytoreductive nephrectomy in current era, it is the end of the beginning or is the beginning of the end? So in your practice, do you still consider cytoreductive nephrectomy in a patient who is planned for TKI, or that is practically out, at least in intermediate and poor risk patient population? Dr. Ganesh, if Dr. Tangokas is not...
I think sir is muted.
I think Ganesh, you can also answer this question.
So what we currently would like to do is discuss each of these cases in a MDT. I think sir is unmuted if he wants to answer, otherwise I'll continue.
No, I'm not unmuted. I'm okay.
Sir, he asked you, so you can go ahead.
Yeah.
Okay.
The indications for cytoreductive nephrectomy. Yeah.
I think there is some...
I think in patients with synchronous metastasis, you would do a metastasectomy along with the radical nephrectomy and you aim for a cure. Patients who have multiple metastases, I think what I would do is patients who are good risk would certainly have, and I usually use the Heng's guide, and those who are good risk would certainly have a cyber risk, will have absolutely no benefit, actually harm with a cytoreductive nephrectomy. So there's a definite no for that. In intermediate risk, again, those who probably have just one high risk factor,
I think, sir...
those can...
I think there is some...
I think there's an issue with his net.
So, Ganesh, what's your quick take on call regarding the Carmina and SIR time? So, sir, your voice is not very clear, sir. I think there is some disturbance. Ganesh, can you...
What sir is saying is, even in IMDC 1, we would probably go ahead with a cytoreductive nephrectomy, and at IMDC 2 onwards, probably we all know we would continue with systemic therapy and would consider the good response patients for a deferred cytoreductive nephrectomy. That is also after discussion in the MDT, probably.
So now I'd like to take our medical oncologist. So what's your take on call regarding the Carmina and SIR time? Have we changed our practice of a cytoreductive nephrectomy after the result of these two trial data?
Yes. Only it should be considered only for favorable risk patients, not for intermediate and poor risk.
Dr. Vinit, so in a TKI, still we use TKI a lot. So where you place the cytoreductive nephrectomy in your practice?
So there are two situations. One is when you do an upfront cytoreductive surgery, and second is when you do a deferred cytoreductive surgery. So now the switch is more towards a deferred cytoreductive surgery, like a SIR-time trial, where they find that benefit is much more when you want to do surgery.
Yes.
So like Dr. Deepak said, if you go by the IMDC criteria, if it's a good risk, then definitely you can do it. In the intermediate risk, if it is intermediate 1, then probably still, if you have a small tumor load, metastatic load, then probably you can think of doing a cytoreductive surgery. Although it has to be discussed in a MSc, because intermediate 1 may behave like a good risk.
Good risk.
Intermediate 2, it's a big no.
Yes.
We have to do systemic, and in poor risk, we have to go for systemic.
I think Chirag, you agree with...
So in general, I agree with what Vinit said. But when we are talking about metastatic RCC, nowadays I will want to...
No, we'll discuss the second scenario later on. So in a TKI setting...
At present, I want to ensure that patient is not having an oligometastatic disease. If it is oligometastatic, I will do everything.
Yeah, so so in a day-to-day setting, mostly it will be multiple metastatic.
Yeah.
So
I agree with
Vinayak. So Dr. Govind Babu sir, do you agree with this that now with the availability of this Certime and Carbonyl trial, so I think that has made life easy for a medical oncologist, so that at least we can what we call as we should not call as a futile cytoreductive nephrectomy, but at least now the place of a cytoreductomy is little bit clear that a good risk, go ahead, intermediate one, assess the patient. In the intermediate 2 and poor risk, start the TKI, reassess if they do well after 8, 9 or 10 months. If the general condition is well, other side is responding, then what we call as a deferred cytoreductive nephrectomy. Sir, your take on call this?
Yeah, Ashish, I agree on the statement that you made. I think, as medical oncologists, we always were more or less certain that radical nephrectomy in a metastatic disease is futile. But now we have strong evidence, you don't have to just say, this is my opinion to your surgeons. You
So
can
it has
say there is
level 5
evidence
to
and
come
that's
to the
why we
level
did.
1.
Yes, exactly. That's right.
So I think this is just the data what we are discussing. So I think I will just quickly skip these slides and we'll go to the next burning question. So I will like to ask Dr. Vinit, so where you place the cytoreductive nephrectomy in immunotherapy era? So this was the discussion in the TKI era. So is it the same or the things have changed over with the use of more and more use of immunotherapy in first line metastatic? Do you still follow the same criteria? Deepak, you can take on.
Yes, it is same criteria.
Do you have some different opinion that?
Yeah, almost the same, because
So
until
still
as
the same-
until as the histology is a different sarcomatoid, then probably it would have a
So you may look towards the histopathology in the initial, and if there is a sarcomatoid, you may go for a cytoreductive nephrectomy upfront followed by TKI. Chirag, what's your take on calling immunotherapy?
So, when the systemic therapy improves, it improves the progressive survival, it improves the overall survival. It becomes a stronger case of offering the local therapy at some point in time. So it is bigger no than only TKI in the beginning, but maybe yes, and more stronger yes if the patient survives for long enough.
Vinayak?
Yeah, I agree with previous speakers that nothing changes much. But I think I reviewed the literature. There are nice, interesting studies where they randomize the surgeon only. So that will be interesting to see. Because we don't have
That's
choice.
a different, we will discuss at some point. So I think what we can conclude that there is as such no randomized data regarding the benefit of the cytoreductive nephrectomy as in the TKI. But this trial, the probe, which is probing the role of cytoreductive nephrectomy in advanced renal cancer. So I think this study is going to be the game, or this will give the real answer whether the cytoreductive nephrectomy is helpful in this scenario. So if you look towards the inclusion criteria, so in this they are deferred, like a TKI, the deferred cytoreductive in this trial, the same they have done. After the initial start, after 9 to 12 weeks of immunotherapy, the patients who are responding will be considered for cytoreductive. So more or less, design is like the Certime trial. So start with the immunotherapy, responding patient. One arm will continue with the immunotherapy, the other will go for a cytoreductive nephrectomy followed by continuation. And the hypothesis what they have proposed that initially because of the load of the initial antigen on this might explore the more T cell to kill the tumor cells, and those tumor cells which are resistant to the immunotherapy, they will be removed by surgery. So I think that we do in day-to-day practice also, that at least what I follow, that if the patient crosses 1.5 year on a immunotherapy, otherwise very well controlled disease, we may discuss with the surgeon if it's easily operable lesion, I go for a cytoreductive nephrectomy at least if they cross 1.5 year. So it's the same practice, Vinit, what you follow? Or something different approach, because there is such no level 1 evidence to suggest in immunotherapy era.
See, the immediate reaction would be that we should discuss these patients in a multi-specialty clinic, and it should be a joint decision. It can't be an individual decision.
So
because the surgeon has to say when the surgeon can come in and get the best benefit, and as a medical oncologist, I have to say what would be the best modality at that point of time. So this would be a kind of a quasi-neoadjuvant setting.
Yes.
So like that Neo-Eva-Exa trial. So we have put 1 or 2 patients but they are individualized. They are not like the standard run-of-the-mill where, you know, you see the criteria and you put it. So that is after a very careful discussion, not otherwise.
Chirag, what you do, so suppose some patient has responded very well, the lung lesion has disappeared. Now the lesion is already in the kidney, 1.5 years has passed. Do you still want to defer that, or you want to just remove that? That is the only source, why not to remove? And surgery is comfortable that it's a easily doable surgery.
That's it. So when I just said that longer the survival with the treatment, the more of the interest will be for offering local therapy.
So I will just like to ask Ganesh, so is there any thing which make it difficult to do surgery after the immunotherapy? Is there any possible hypothetical reason that patient might have received the immunotherapy, there might be more fibrosis, something? Is there any theoretical concern in your opinion?
Actually not. I mean, if the CT scan is studied as usual, I don't think there is any concern because of immunotherapy. If the disease is remaining back, the lymph nodes are there and encasing the vessels, okay, that is totally different reason anatomically. I have done even robotic surgery post-IOs for a deferred cytoreductive and it has gone pretty well.
Yes, so I think we have done
So I didn't find any difference personally.
So I think we have referred some patient, I think they surgery was very well, there was no major post-op or complications. So I think that is not a challenge. So in case-to-case basis we can consider. Govinda, what's your take on call with this situation?
Yeah, I agree on that. My other thing is I think we'll start, having some more molecular biomarkers, the ctDNA, CTCs, all this will come in because we are now just seeing such fantastic
like
responses in renal.
So
yes, absolutely. So it is not extended so far into renal cell, but I think that is the way we will go forward. We will look at the tumor burden, how it has come down, and monitoring on the CTCs or ctDNA. I think that is rapidly going to come into renal cell.
So I think what we can take on from discussion
that's how I see it.
The cytoreductive nephrectomy in a immunotherapy area is still not clearly defined. Individual decision has to be taken as per the response, and in a MDT we can take, but there is some scope that patients who are doing very well can be considered at some point of time if it is. So I think the same patient was on observation, and after follow-up after 2 years, developed the routine surveillance, developed the multiple small 5 to 7 millimeter bilateral pulmonary metastasis on CT scan. Patient was asymptomatic, rest lab parameters are normal. So is there any possibility of active surveillance in this patient, Deepak? So will you like to start some therapy, or you might like to still discuss the active surveillance in this patient? Asymptomatic multiple pulmonary metastatic lesion, 5 to 7 mm.
You can go for active surveillance. If the patient is asymptomatic, disease volume is low,
but
small mets.
In a day-to-day setting, how comfortable you are discussing with the patient's relative that we see the disease in the lung and still we don't want to do anything? No, at least I am not able to convince.
We have few patients on surveillance.
2 or 3 patients. Dr. Vineet, what's your take on call with? Have you ever put any patient on active surveillance? I have till the time one patient was there. He was 80-year-old, so family agreed for that. Otherwise, it's very, very difficult.
See, that is what. Putting patient on surveillance, you have the criteria, everything, like Deepak has said. But the most important thing in this is discussion with the patient and the attendants, which is a pre-surveillance counseling, I would say. So if you are able to convince them, then nothing like it. And if they fit the criteria, low volume disease and everything, then probably you can put on surveillance. I have 2 patients on surveillance.
But this number is single digit mostly.
Yes,
Chirag,
yes.
Chirag, what's your?
So there are 2 extremes of thought on that. On one side, we say that theoretically it is possible, scientifically it is possible to do the active surveillance. And then we need to define what do we mean by active surveillance. Is it CT scan rigorously every 3 months and so on and so forth, and the compliance is an issue. And on other extreme, with every TKI IO combination, we have the excellent outcome. The delta is excellent for the favorable risk patient. So why to offer them surveillance? Why not to treat if the patient is affording?
Vivek?
I think patient factors decides this thing. Otherwise, I don't see a scientific background to surveillance.
Yeah, so I think you are right that as such the data is only one of the phase 2 prospective data in which they ultimately divided the patient on based on the IMDC risk and number of metastatic. So if the IMDC is 1 and the less than 2 metastatic site, the median surveillance duration was around 22.2 months. So surveillance is practically very, very difficult to offer. Only where subset of the patient, yes.
With less than 2 metastases, I would like to operate everything.
So sometimes with surgeon 7 mm, 8 mm, they are not, so you are difficult to localize those metastases on when they open. So very small lung metastasis, thoracic surgeon might find it very difficult to localize. So I think ultimately it's the good biology. So IMDC 1 and less than 2. So in a rare, in a patient who are elderly, not very keen, associated other cardiac morbidities where we are not able to. So in some group of the patient, selectively patient, we can consider there is at least a prospective phase 2 data for this. That is the only benefit with this paper we can discuss with the
See, Amit, patients whom you put on surveillance, you don't find them every day. It is not a run of the mill. They are specific patients, either extremes of age, they have comorbidities, elderly patients, low volume disease, in which you feel that the patient is doing well and the patient has a good performance status. You might decrease the performance status and the quality of life indices of the patient
by giving the
immunotherapy or TKI or whatever, and you might think it is good risk. So these patients are far and few, but then they are there. It is not that they are not there.
Yes, and we have at least a phase 2 data at least to
and surveillance shows that you can prolong their quality of life, and of course the disease free survival or time to treatment interval.
Because all these TKI or immunotherapy will have its own associated toxicity. So I will just take a quick...
Ashish, just a comment here. Maybe if they're just such tiny, we can look at SBRT also, where you don't want to give any treatment,
Next discussion.
Okay.
So, if Dr. Tangaonkar sir is there, I think he's not there. So I would like to ask Ganesh. So, suppose the patient has a recurrence at local site after 2 years. And there is a 1 lung metastasis. So how comfortable to operate in a patient in a renal bed where it has been already? So do you find any real challenges in operating those patients in there is a renal fossa recurrence? And what time period do you want to? So if recurs within 1 year or say recur after 3 years?
Yeah, of course, it will make a difference. Because, very soon after the surgery, then obviously there must have been some residual disease at the time of the primary surgery. And that only happens if there is an extensive disease to begin with. Okay, so obviously somebody who gets a recurrence after 2 or 3 years has a relatively slow growing disease. And these patients, if of course you see the CT scan properly, see the aorta or the IVC is not invaded, and if it's fine, then we should definitely go ahead and do the excision of the recurrent mass in the renal bed. At the same time, we also look at the lung metastasis. I mean, if it is something which can be easily localized, then certainly you can do a thoracoscopic excision of the since it's solitary metastasis. So that these patients, if the RFI is more than 2 years or so, then they would do well.
Yes. So I think in case-to-case basis, if the disease-free period is longer than 1.5 year or 2 years, and disease is easily resectable, there is definitely a benefit of doing a primary, there is a recurrence or if there is a metastectomy. I think Ganesh, do you have a different opinion or you will go ahead with the same opinion?
No, same opinion. I mean, the scenario you said was very specific. Sometimes we commonly see the other scenario which we used to discuss in TMH MDTs, that there is no metastasis, but there is a local recurrence. Again, it was on case-to-case basis, operable, not operable, operable obviously with vascular help and whatever. And as sir says, surgeries are sometimes difficult, but it is case-to-case basis, good decision should be taken to operate.
So I think we have a radiation oncologist, Kundu, in panel. So where you place the RT in this situation, the SBRT and all that, and we had at least in TMH few good experience with that. So how comfortable to give SBRT to the lung lesion, and how long you expect the control from this?
Yeah, definitely, sir. For the lung lesion, we can definitely go ahead with SBRT if the surgeon does not operate or metastatictomy is not done. For the kidney local renal fossa recurrence, it's a bit tough to do SBRT because it's basically a mobile structure. So if surgeon feels difficult to operate due to fibrosis and less duration than prior surgery, then we can also do a SBRT on that area also. But for lung, it's a very easy case.
So in a case where it is surgery is not technically feasible, so we can explore the possibility of SBRT. So this is one of the very, while preparing, I find this study is a Rappaport trial. So it's a phase 1-2 study of stereotactic radiotherapy and pembrolizumab with oligometastatic tumor, and which may be relevant in our scenario where there are resource constraints. So this is the study. What the inclusion criteria of the study was that patient with the oligometastatic, that is 1 to 5 metastatic site disease, and one or more which is amenable for SBRT, and that is followed by only 8 cycle of pembrolizumab. So this I find that in our scenario, resource constraint, in few patients we can consider the SBRT is available. 8 cycle of pembrolizumab patient can be offered. So this is one of the data, and the result of this study shows that the long-term control is comparable to the patient who received the full course of immunotherapy. So this is one of the study which we can explore in our setting, that a few patients who are in this range of 1 to 5 and one of the lesion is amenable, this can be considered. So there is definitely a role of SBRT, and this we can explore in our patients. So I think now comes the real plethora of discussion. We usually discuss the metastatic, the florid metastatic disease, where and which agent to be used. So we all aware that we stratify the patient on this basis. So I will just quickly ask with all, at least medical oncologists, that what is their choice and how they take on call all this combination, because it's the problem of too many, which one to choose and which one not to choose. So in day-to-day setting, patient is affordable, a good volume of disease, patient is mildly symptomatic. So which one is you prefer in suppose the PAP is not there is no PAP program in till now at least. So Deepak, which combination which you will prefer? LEN plus PEM, AXI plus PEM, AP plus NEO plus Cabo.
So patient has been operated 1 year back, now with lung and
so
bone mass.
IMDC take for 2 for discussion, or
so
3.
Intermediate. So in intermediate risk, immunotherapy with TKI. Or
not IO plus IO. You
or
will not
immunotherapy both.
So which one you will the patient will say, Doctor Sahab, आप decide करो. Most of the time but the patient say that आप ही decide करिए हमारे लिए क्या करना है.
Then I will prefer immunotherapy with TKI.
With TKI. Which combination of this all? PEM plus AXI, PEM plus LEN, or Nivo plus Cabo, or the last one, the AXI plus Avelumab?
Cabozantinib with nivolumab.
Nivo plus, any specific reason for selecting this combination?
No specific reason, but I think it is more tolerable as compared to lenvatinib with pembrolizumab.
Vineet, what's your take on what is very difficult to decide in the OPD which one is?
So first question was IO plus IO versus IO plus TKI. So in that, I would look at the patient symptomatology.
Not much symptomatic.
Asymptomatic. So in that situation, I would be going towards IO plus IO, because I would go more for durability of remission than the response rates.
And if you have
even if you have this lenvatinib plus pembrolizumab, which is showing the highest CR rates, but how many times, in practicality, you tell me we reach a dose of 20 milligrams of lenvatinib? Almost never. So if you don't reach it, then how do you get the results?
So among IO plus TKI, which one will be your choice?
In that, I would choose PEM plus AXI, because the side effects of axitinib are very well defined. It's a short acting, it is not a long acting.
So the overlapping toxicity can be easily, we can easily pick up.
I would be skeptical for nivolumab and cabozantinib, because cabozantinib is not a very good drug to handle. You have a lot of GI side effects.
Toxicity, cabo, even single agent is
PEM-AXI I would, and the body of literature is maximum with PEM-AXI at this point of time.
Chirag?
So, with the assumption that the patient is affording, right?
Yes.
If the pathology is showing significant sarcomatous component,
no,
I will be prompted to look at IO-IO combination. Otherwise, I have maximum experience and I am comfortable with, as I said, pembrolizumab, axitinib. we could use the other combinations as well, but that would use up lenvatinib or cabozantinib in the first line, which are the
So
good
you want
drugs
to
for
keep
second
the
line
other
as
option
well.
reserved for second.
Yeah.
Vinayak, do you have a different?
Yeah, same thing. I would use IO in sarcomatide and high risk thing. If given choice IO and TK, it will be preferably, I prefer to use Nivo and Cabo for not academic reasons. But if it is given choice, Pembro and Axitinib is my choice.
So, but in day-to-day setting, Dr. Vineet, how many patients, if you plan 10, how many will go for IO plus IO and how many will go for IO plus TKI? In a day-to-day setting.
I think a majority would be with IO plus TKI.
TKI.
Not IO
So I
plus
think
IO.
despite the robustness of data, I think because of the concern of the which we'll discuss. So why you, what are the concerns while planning for IO? What are your concerns why you don't want to prefer IO plus IO over the IO plus TKI? Despite this robust data, concern that why you want not to choose the IO plus IO?
No concern. I mean, we are used to using Pembro, Axitinib in good number of patients. We are comfortable. So that's it.
I think the pathway is also EGFR driven, so we don't want lose that opportunity to target EGFR also. I'm sorry, VGF.
No, if I find that the volume of disease is too high, if the patient is too symptomatic, and I want a quick cytoreduction or I want a quick symptomatic relief, then definitely I will not go for IO plus IO. I would go for IO plus TKI.
I think Dr. Govind Babu sir is also, so what, sir, what's your take
Yeah,
on
I think
all of this?
I think what Vineet told is right, but you know the CTLA4 also has some toxicity. It's not that it is pretty safe. So I think we need to look into that as well. You know, just to tell you, last 3 patients are metastatic. I gave them all the options. One chose pembrolizumab plus lenvatinib. Other one wanted nivolumab plus cabozantinib. So I explain everything to them, and I tell you, because we have so many. You decide what you want to, but I'll give it toxicity of them is better as compared to cabozantinib. So that would be a good choice.
So is this, Vineet, is this a concern for you that the best response as a 25% as a PD? So is this one of the things which comes in the mind when we discuss or plan for this, that 25% patient will have, so is this in your back of the mind, at least do you consider this fact that 25% patient didn't respond yet?
So, Amit, there are 2 things in this. One is if you talk of pure academics, the other is of real life scenarios. So if you talk of real life scenarios, as Chirag has said, there is a level of comfort with the drug.
Yes.
You know, you have used Pemaxi, you have seen the responses and you have seen less side effects. You have given Epinivo, you have seen the side effects of Ipilimumab, and sometimes they are disastrous. I had one patient, and that also comes into the decision making because you are spoiled for choices.
Yes, so I think what the discussion was going on that, so in patients who is much symptomatic and we want a quick response and the ease of the administration and the toxicity which we are comfortable dealing with that. So in most of the time, around 80% patient, or I can say that 90% patient will go for a IO plus TKI. Very few selected patient with limited volume metastatic disease with a good performance status, the IO plus IO can be considered after discussing everything from the patient. So this is just showing the how the response rate is improving over time in due course of time, and this is the how the PFS is improved over time, which started from interferon from 5 months. Now we are reaching at the PFS of around 24 months. So definitely the management of RCC has evolved over time. So I will just skip this slide. This is just showing the survival in the era. So this last is the interferon era, and this is the this one the combo. So if you see the flat, the curve is flattened, and the last, the upper one is that what we are that all patient metastatic will, at least the majority of them will survive over period of time. So I think with this availability with newer options, the survival is definitely improving over course of time. So what about this? So this was one of the study presented in the ESMO. The combination of Cabo, Nivo and the the Nivo EP plus Cabo. So there was concern of disease progression. So this Cosmic 313 study, the Nivo EP plus cabozantinib versus the Nivo EP plus placebo. So do you see the future of this trial? And this has shown the, at least the PFS has not reached in the combo of EP Nivo plus Cabo compared to the, so do you see the future of this trial? Cabo, the Nivo EP Cabo triplet, like a prostate cancer.
I will want to do a further trial of Cabo, Nivo EP and everolimus. Anyway, this is overkill, and I feel that I will desperately want to look at the long-term outcome of this trial, but at present I am not inclined to use the triplet ones.
Since the toxic, but definitely the people are thinking beyond that, and whatever the concern for a disease progression while on IO, this they try to answer this question, and definitely we have to wait. What's your take on call, Vineet, on this data?
See, that is one issue. The other issue is that you put, you fire all the guns in the first line.
If you take the same
you're
analogy,
left high and dry in the next one. What do you do?
So the same analogy is for the prostate cancer also, where we are using the triplet. So we cannot say that that may be, but we have to wait for this. Dr. Govind Babu sir, what's your opinion regarding the?
Yeah, Amit, what Vineet told is right. My more of a concern for this study is looking at the toxicity. You have cabozantinib plus ipilimumab. Both have increased toxicity as compared to the other TKIs. So I think that is what I need to look at
But if you read the toxicity in trial, it's not that. I don't know. When you do in the practice, whatever the written in
exactly.
So what I do,
exactly.
I just add 10 to 15% from the literature. So it is 50, that will be in practice, it will be 60.
International standardization of toxicity. Yeah, that's true.
Yeah, so just a quick discussion regarding the patients who are not affording for immunotherapy in first line, at least in intermediate and poor risk. What's your, quickly, patient not affording for immunotherapy, intermediate and poor risk?
My first choice would be cabozantinib.
Cabozantinib. Vineet?
Yeah, cabozantinib.
Sunitinib or pazopanib.
Oh,
because
at least
because we have data,
I know that you will give answer.
We have data of cabozantinib after sunitinib. We don't have data of sunitinib after cabozantinib.
Yeah.
But still, this is a randomized phase 2 trial, the cabozantinib trial.
Phase 2 trial.
But it's still,
I think
and since the generic is available, so we have a choice that we can.
all are same, but I would prefer to use, like sir said, Pazo and sunitinib.
So you are still this old school of thought.
No, sir. For good risk or intermediate risk, one.
Intermediate and poor. So if you see, it's around 8.2 versus 5.2.
Cabo is not an easy drug. Huh? The message is Cabo is not an easy drug to do.
See, Amit, you have clearly defined that this patient cannot afford IO drugs.
Immunotherapy.
So this is a niche situation. This is not a run-of-the-mill
So
situation.
most of the time in our OPD patient is not affording for
So if you see the response rate, best are with Cabo.
Yes, so even the only thing is that the toxicity, if you read, that is the only concern. So the other point of discussion, what dose do you prefer? Starting 60 or 40? So starting 60. So how many patients view, at least I am not able to, whenever I started 60, at least in 50-60% patient, I have to come down to 40. So now also, we just so step up rather than step down.
I think one thing unique, I mean, is there in the literature as well as the few of the international experts saying, like I do 5 days of TK and give 2 days gap with 40 mg. They are tolerable. Some patients don't tolerate that also.
So Dr.
Radiotherapy concept.
And there is data to suggest that 40 works equally well.
Yeah, that's right.
So, Dr. Govinda, you also go with 40, not the 60.
I start with 40, yeah, that's right.
So that is the only, so if the patient is responding to IO, completed 2 years of immunotherapy and TKI is ongoing, so do you want to abruptly start at 2 years and patient is affording so that they can consider afford? Do you want to stop or you want to go at least for 6 months or something like that?
Please, can you repeat the question? So patient has completed 2 years of immunotherapy.
2 years of immunotherapy and TKI, now there is no disease in the PET, complete metabolic or morphological response.
You discuss with the patient, he can continue.
If they are okay with that, cost is not a constraint, because I have 2 patients like this in last 2 or 3 OPDs.
Then I will continue.
Vinith, what you will do? You will abruptly stop, or you want to continue some six weekly or 100 mg something?
See, it's riding a tiger, you know. You come out, it'll eat you up. So there is no data to suggest to back up.
The real practice, do you consider or not?
So the consideration is there, discussion is there, but you know, eventually the patient will ask you, what happens if the disease comes back? So that I'm not able to answer, so I will continue.
So the answer is that I will continue, but to substantiate that, you know, if the tumor volume curve with time is straight going down and straight at
zero. Now there is no NED.
It is
Now
NED.
there is no disease in there. Kidney has
Then
been
in
operated.
that case, I will stop. I mean, at the end of 2 years.
I continued that patient for six weekly. The family was very concerned. So वापस तो नहीं आ जाएगी. अब दे दो, toxicity नहीं हो रही है. So that I'm not. I told them that I'm not very sure, but I don't want to abruptly stop. Let's give for that. I don't have a scientific data for that. Dr. Govind Babu sir, what's your take on all this?
Yeah, in fact, the patient themselves were saying, okay, we want to continue. So I know, like you said, we don't have the.
But I think the real problem is with the TKI.
Yeah,
so the patient developed the proteinuria and exitinib. So that is going to be a real challenging point for me rather than the immunotherapy.
Correct.
And if you ask the international expert, they say that TKI needs to be continued. But if you continue for beyond 2-3 years, the usual toxicity of the TKI comes into the picture.
See, Amit, intolerance is there, that is a different issue. You said that disease is NED, will you stop it or not?
Yeah.
At least I continued in.
It's a catch-22 situation.
Yeah.
So nobody knows
like
the
you
answer
said,
of this question.
Like you said, I am also, prolonging the time of 2 doses.
Yes.
And that's what I'm doing. But I think these are opportunities for us to really look at ctDNA and some sort of a monitoring like that when they are NED, So I think this will rapidly come into renal cell as well, like we are doing for other diseases.
But then, there might be a situation where you used IO plus IO.
That is the another good point with the IOI, that you can stop at 2 years.
If you take a corollary from melanoma, in those patients who had toxicity, you stopped Ipinivo. Even for 2 years, the effect remained.
Yes.
So that could have been extrapolated, but with the TKI plus IO, I don't know.
Yes. So I think that is the one good point with IO plus IO, that if the patient is CMR after 2 years, you can safely stop it. So I think that we'll just quickly discuss the second line therapy after first line of a patient who receive IO plus TKI in first line. What will be your second line therapy and why? Just quickly, because we'll just nearing the end of this. Second line therapy post IO plus TKI progression. Deepak?
It is lenvatinib with everolimus.
Any specific reason for that? And the
lenvatinib dose is 18 mg, but most of the patients, they don't tolerate 18 mg.
So the same question here,
and
dose.
everolimus also even 5 mg I have seen patients.
And not cabozantinib? Between the cabozantinib and len plus avro, what you will choose, and any specific reason for len plus avro?
No specific reason.
No specific reason. Vinith, what's your take on call? Second line.
Second line, I would like to give cabo.
There are two scenarios. One patient which progressed very rapidly, and one which the disease remained controlled for a 2 year and now gradually progressing.
So, gradually progressing, I can give cabo, single agent. If the patient has progressed very quickly, then
so I think there is some indirectly evidence that patient who respond well to the one TKI for a longer, they may respond to the second line of TKI. So in patients who progress very rapidly, generally that what your take on call, Chirag, on this second
I agree
line?
with what Dr. Vinith said, but the thing is that with cabo we have a good randomized phase 3 trial. For lenva everolimus we have phase 2 data only. So
but still all these are the, I think, category 1 option in the NCCN.
Phase 3 is so phase 2 study.
See,
But anyway,
the thing is that if the patient has a long duration with the TKIs, then you can give a second TKI.
That may respond.
If there is a short duration with TKI, then it is better to change over. That you've seen with sunitinib and axitinib. Those patients who had a long stint with the sunitinib, they tend to do better
well
with
with the
exogenous.
So I think that is some indirect rationale for choosing this, those who respond. So I think Dr. Govinda, do you follow the same approach what Dr. Vinit was discussing?
Yeah, the same thing. But recently I came across a small study which looked at patients progressing on pembro or nivolumab responding to atezolizumab. But again, this is a very small study. So that is just some data there.
I think practically, Atijo is practically.
So there is a very interesting article in this year's ESCO educational book about second line after IO as the first line, and all the various options have been discussed with no clear preference of one over other. One of the option discussed in that was the addition of nivolumab in whatever immunotherapy you are using. Addition of ipilimumab in whatever IO that you are using. But there is no clear preference of one over other.
So I think there is some evidence of data that CTLA-4 inhibitor can be considered. So there is some I think I'm not sure, but it's a phase 2 study that if IO plus TKI, then IO plus IO can. So like the patient has received pembro plus XZ, then Nivo plus EP can be considered in phase 2. So there is some data regarding the combination of IO. Otherwise, most of the time, the only thing is that there is no head-to-head trial comparison of cabozantinib with len plus avro. That will give the answer of the best choice, but it's not head-to-head compared. Otherwise, len plus avro in patient who progresses rapidly, or in cabozantinib in patient who responded well to the TK, that we practice in day-to-day.
Or sometimes when the patient has been on Ipi-Nivo, continues on Nivo for a long period of time, and there shows a difference, in that you can reinitiate, add ipilimumab.
Ipilimumab, yes. So I think what's your take on call regarding these two agents which is coming very rapidly in the RCC setting? This tivogentinib had already been approved in, I think, Western world, but it's not available in India. But what's your own call? So so now we are looking towards the third line and fourth line in the RCC. So Dr. Vinit, what's your take on call with this hypoxia inhibitor, which the phase 3 trial is already ongoing?
Definitely not in the first line, probably in the later lines. We can take it.
I think we'll just skip with this.
So Amit, the HIF has been studied so much in renal cell, but only now we have an agent to target it. So that's how I'm seeing it.
Yeah, so I think that is the curve which I discussed, that there is a flat curve started flattening, and we can see long term, like a breast, we have a multiple line of therapy in metastatic setting.
Correct.
So I think I will just skip this. This has already been discussed with us. So I think tivogentinib, this is one of, if you look to the data of tivogentinib, that's looks a quite promising molecule in third line. So this was a third line study of tivogentinib, and if you see the response rate, partial response, so it seems to be that even in a third line the TKI works. So in a fitter patient, whenever this drug is available in India, we can have one option for this. So now this is the last point of discussion, immunotherapy toxicity. So we all know that we have to give immunotherapy. So in day-to-day setting, how commonly you see, so I will start with Deepak, how commonly you see the immunotherapy toxicities in, at least in RCC, when you give the IO plus TKI, then IO plus IO. So out of 10 patients, how many will develop, have you encountered?
5 to 6 patients will develop some toxicity.
Grade 3, 4? Grade 1, 2, it's okay, we can, grade 3, 4 toxicities.
3 to 4 patients.
3 to 4 patients. That means 30 to 40% patient will develop.
So IO plus IO, they'll develop more versus IO plus TKI. If you say IO plus TKI, grade 3, 4, probably 10% or 20% maximum. But it is more in IO plus IO.
Chirag?
IO, I have just a couple of patients, so there is no point in quoting my experience. I can quote the literature only, which everyone knows. IO TKI, in my experience, grade 3 toxicity. I mean, I didn't see any grade 4 toxicity. Grade 3 in about 15% of the patients.
15%?
Yeah.
Vivek?
So in the IO plus TKI combination, 30% will have some side effects. At least 10% of them are seriously troubling. Like one patient of IO had a very high TSH, and someone gave Avil, he went to the thing. So that kind of incidents also happen. But luckily, most of them respond to steroids, and a treatment-free interval also helps.
Govind Babu sir, what's your experience with the IO toxicity, IO plus TKI, that what we
Yeah,
commonly
about 15 to 20%, yes.
So I think that is the ball figure, that around 10 to 15%
Yes,
we
yes.
develop. So what are the challenges in managing the toxicity? So in day to what challenges you face managing these toxicities? When to start steroid, how long, when to taper and all.
So we need to have the team of specialists, maybe pulmonologists and gastroenterologists and neurologists and dermatologists, who are working closely with us and who have the knowledge of immunological side effects of our drugs. If they are there with us, we can manage the toxicities easily. We have to be accustomed to grading of the toxicity as per
criteria.
the criteria, and as per the criteria, we have to manage the toxicity. An extra effort is required whenever the toxicity appears, and then the things are easy.
Vineet, what are the problem you faces with this? And the other next question is the steroid nuances, sir. So when you start the steroid, the other second plethora of problem starts.
One is the grading of the toxicity, and you manage it accordingly. Sometimes you have to stop it abruptly. You cannot reinitiate the drugs in 2 or 3 organs if they are, especially if it is choroidal or patient has encephalitis. Or then the other thing is that there is a timeline. Now we have seen that certain organs come late in the picture whenever the side effects are there.
So I think that is a very important point. Which
certain organs are
timing of the toxicity. So we have to be mentally ready that this toxicity most commonly what we see. So what are the problem you face or challenges with the use of steroid?
Steroids.
Because in our scenario, if you start 1 mg per kg for 4 weeks, then other issues of...
if it's an elderly patient, if the patient has comorbidities like diabetes, it gets aggravated, it has its own problems. And sometimes when you start tapering the dose, the side effects flare up, you have to... So it's a, like a war which is going on. So all these side effects, conventional side effects of steroid which are there, that is the one we face. Problems sometimes in 1 or 2 patients I've seen, moment you start tapering the dose, the flare up of the side effects occur. So in that situation you might be caught sometimes.
The other thing which I want to mention about the PCP and the fungal pneumonia, at least I had a very tough time in 1 or 2 patients, and the patient was G6PD deficient. So even it was very, very difficult for us to whether to give him what sort of prophylaxis and all that. So the message is that although it's relatively safer, but the some patient who develop the at least grade 3-4 toxicity, you have to be on the guard. You just cannot send the patient the hyperglycemia and all the issues. So those who develop the toxicity, they need very close follow-up. And what Chirag was saying, that it's very, very important. In Tata we lack, and sometimes so a multidisciplinary approach is very important. You should have a dermatologist who knows about the immunotoxicity, the gastroenterologist who is aware of the toxicity, ready to do the GI endoscopy on your call, pulmonologist to ready to do broncho. So you need to develop a team with your colleagues who are well acquainted with these toxicities, so that can be managed at right time, because if you delay, the patient may develop more complication. And the last 2 questions, how many steroid refractory disease do you see in practice?
I have not seen.
Vineet?
I had 1 patient, I had a tough time.
So what was the toxicity?
The patient had diarrheas, refractory colitis, refractory diarrhea. It wasn't, so we had a tough time, but fortunately we gave ultimately mycophenolate.
Yeah, second line.
Settled down.
And he responded to that, fortunately.
Yes, fortunately settled down.
So one patient with altered adapty, the enzymes were not coming down with 1 milligram per kilogram of steroid, was given mycophenolate, and then it came down. But apart from that, I didn't had the opportunity of using anything beyond steroid.
Vivek? So I will take the final word from Dr. Govind Babu sir, and then regarding the immunotherapy toxicity nuances and how to manage all this. Sir is there? Sir has gone. So I think that is the last slide. I think like breast cancer, lung cancer, practically no one, now we are moving towards the molecular based subset classification. So that what we are discussing, that which patient is going to respond which type of therapy, IO plus TKI, only TKI. So in due course of time, like a breast or lung, we send the tissue for some specific marker. This is the era which we are heading towards that. And that is my last slide. And I thank my all panelists for active participation. Dr. Hemant Tungawkar sir, Dr. The Ganesh Bakshi and Dr. Govind Babu sir for actively present. Thank you, ICON for giving this opportunity.